Welcome, everybody. I'm Paolo Cassano. Welcome to the MGH brain-PBM rounds. Today is May 24, 2024, and it's my great pleasure to introduce Professor Ivan Maksimovich, who is presenting on transcatheter intracerebral laser photobiomodulation therapy for ischemic cerebral lesions. Thank you so much for coming in today. And we also have an interpreter, Liza. Thank you so much, Liza, as well.
Sure.
So do you want to interpret? And Dr. Maksimovich can also share his screen with us, and we can get started.
Доктор Иван Васильевич, вы хотите поставить презентацию?
Да, естественно, можно, я хочу.
Вы можете это сделать?
Да.
Давайте. He's going to do it now. Can everybody see?
We can, yeah.
Okay, I will start. I'll just want to warn everybody, I timed myself. It will take approximately half an hour to 35 minutes. It's a long presentation, and because I'm not familiar with the matter, I'll be reading everything. So just to manage everybody's expectation. So we will start now. Dr. Cassano?
Okay. Please, thank you.
All right, so this is a clinical application of transcatheter intracerebral laser photobiomodulation therapy, PBMT, for atherosclerotic ischemic brain lesions by Ivan Vasilievich Maksimovich. Next slide. Ischemic lesions of the brain are increasingly observed among the population of different countries. The most common cause of cerebral ischemia is atherosclerosis, which affects various vascular pools. Approximately 9.33% of the cases of atherosclerotic lesions are of the extracranial type. 46% of the cases are of the mixed type, and 44.5% of the cases are of the intracranial type. Atherosclerosis simultaneously affects both the main and distal arterial branches and capillaries, leading to cerebral small vessel disease. The most important feature of cerebral blood supply is that 1 cubic centimeter of cerebral tissue contains about 3,000 to 4,000 capillaries, which is much more than in any other organs and tissues. The present research is devoted to the PBMT in the treatment of ischemic brain lesions for stimulation of angiogenesis, restoration of cerebral, distal, arterial, and capillary blood supply, stimulation of neurogenesis, metabolic and regenerative processes in the cerebral tissue. Next slide. Materials and methods. All the examination and transcatheter intracerebral interventions were performed with the approval of the ethics committee, as well as with the consent of the patients examined and treated and their relatives. The selection criteria is as follows: the consent of the patients as well as their relatives to conduct the necessary examination and treatment, the somatic state of patients allowing to carry out the necessary examination and treatment, the presence of cerebral ischemic disorders, cerebral involutive changes, dementia, cognitive impairment, and decrease in daily life activity. 1,872 patients aged from 29 to 81 suffering from various types of ischemic brain lesions were examined, of whom 1,365 were men and 507 were women. Of this, 1,008 patients with distal intracerebral ischemic lesions were selected and were divided into the following groups. 911 patients with cerebral arteriosclerosis and with chronic cerebrovascular insufficiency were selected, and 797 patients with cerebral atherosclerosis with previous ischemic stroke of varying severity aged from 30 to 81 were selected. Next slide. Screening plan. CT and MRI of the brain were carried out according to the conventional schemes. Assessment of the clinical severity of dementia was accomplished in accordance with the clinical dementia rating scale. Evaluation of cognitive functions was done using MMSE. Evaluation of daily activities was carried out using IB. Laboratory diagnostics included coagulatory, biochemical, and general clinical tests. Brain scintigraphy, SG, was done on a higher nuclear US gamma camera, and REG was used for disorders in pulse blood flow in the cerebral hemispheres were identified. MUGA was carried out using the conventional method of transfemoral access. The examination was carried out in direct and lateral projections in the mode of constant subtraction with a recording rate of 25 frames per second. And peripheral capillary blood flow was determined with the computer program called AngioVision. Next slide. Group 1, active group. Group 1, sorry. Patients with distal intracerebral atherosclerosis and with chronic cerebrovascular insufficiency. So the test group consisted of 579 patients, which was 63.5% of patients who underwent TPBM. And the control group consisted of 332 patients, 36.4%, who received just conservative treatment. Group 2 of patients had distal intracerebral atherosclerosis who previously also had ischemic stroke. Among them, there were 3 parts to the test group. The patients who underwent TPBM, according to the size of the ischemic lesions, the patients were divided into the following 3 groups: microfocal strokes, midfocal strokes, you can see the numbers there, microfocal strokes. And the control group were patients received just the conservative treatment. And according to the size of the ischemic lesion, the patients were divided in the same type of groups: microfocal strokes, midfocal strokes, and macrofocal strokes. And you can see the numbers on the page. Next slide. Table 1. There is a lot of information here, but I'm just going to highlight most important things. This table identified changes in the groups of examined patients. The table shows that identified changes found among test 1 and control 1 patients, as well as among test 2 and control 2 patients, are comparable according to clinical dementia identification, cognitive impairment, everyday life activities, laboratory tests, cerebral CT and MRI, cerebral scintigraphy, SG, cerebral rheoencephalography, and cerebral multigated angiography, MUGA. Next slide. Methods. Test group 1 and test group 2. TPBM was carried out for those groups. In cath lab conditions under local anesthesia, multigated angiography in front and side projections is performed following the classical method with transfemoral access. With the help of the digital program AngioVision, the density of the cerebral capillary blood supply is automatically identified. Further, also in cath lab conditions under local anesthesia, according to Seldinger method, the common femoral artery is punctured and catheterized with a 6 to 7F introducer. Through this introducer, under fluoroscopic and angiographic control, guiding catheters go into the intracerebral branches through the common and internal carotid arteries. A flexible fiber optic light guide laser instrument with a diameter of 25 to 100 micrometers, with a perpendicular polished distal end, connected to the laser stand, is passed coaxially through these catheters. The fiber optic instrument is carried to the distal intracerebral arteries, where laser action is performed. PBMT is done using continuous helium neon laser. The time of laser PBMT is about 1200 to 2400 seconds. The parameters of intracerebral transcatheter laser irradiation will be presented in table 2. Next slide. Due to the intravascular application and rather deep penetration of laser energy at a wavelength of 632.8 nanometers, when passing through various turbid biological tissues, the power density along the vessel and in surrounding tissue is variable. For the conducting fluoroscopic monitoring and determining the vascular bed response, radio-opaque substance is periodically administered in small doses. After transcatheter intervention, repeated cerebral MUGA is performed using the angiovision, which allows to automatically register the changes obtained in the vascular image in the corresponding contrast phase in real time. According to the results, changes in the bloodstream, severity of intracerebral angiogenesis, collateral and capillary revascularization are evaluated. If angiogenesis is not sufficiently pronounced after the first PBMT, the manipulation can be repeated, but this was not required when carrying out these transcatheter interventions. Next slide. So here you see table 2. You can read it yourself. I'll give you a couple seconds. After transcatheter and intracerebral PBMT, the patients received disaggregant, anticoagulant, antioxidant, vasodilating, and nootropic therapy. The patients were given aspirin. You can read the directions yourself. Heparin, pentoxifylline, complamine, nortrapil, inosine, intravenously with a drop counter, and then they were given pills. Control group 1 and control group 2 received only conservative treatment. Conservative treatment was given to patients who, for one reason or another, could not undergo PBMT, or they and their relatives didn't want them to have it conducted. These patients underwent therapeutic treatment with similar schemes and doses of drugs used in the post-operative period by patients in the test group. And the drugs are exactly the same with the same dosage, as you can see it above. Next slide. Evaluation of results. The results obtained after the treatment were evaluated by means of CDR, MMSE, and IB. So here we described what is good clinical result. Good clinical result is an almost complete restoration of mental and motor functions and daily life activity. Satisfactory clinical result is incomplete restoration of mental and motor functions, daily life activity. Relatively satisfactory clinical result is a partial restoration of mental and motor functions and daily life activity. And relatively positive clinical result is an absence of negative dynamics with an insignificant restoration of mental and motor functions and daily life activity. Next slide. So here you can see some pictures of the results from group 1, from test group 1, from active group. These were the patients with intracerebral atherosclerosis and chronic cerebrovascular insufficiency. These were the immediate results. According to MUGA, a good direct angiographic result manifested in pronounced angiogenesis and collateral and capillary revascularization, and it was obtained in 96% of patients. If you look at the figure, it describes female, 68 years old, with distal atherosclerotic lesions of cerebral vessels, and it shows before and after the treatment. So in figure A, you can see left internal carotid artery angiogram, arterial phase, before the intervention, which shows depletion of the capillary bed of the brain white matter. In figure B, you see left internal carotid artery angiogram, venous phase, with multiple arteriovenous shunts. It's also before the treatment. In figure C, you can see left internal carotid artery angiogram, arterial phase after the intervention, which shows angiogenesis stimulation, arterial collateral, and capillary bed restoration. And in figure D, you see left internal carotid artery angiogram, venous phase. You see closure of multiple intravenous shunts. Next slide. Now results of the early period, which is 1 to 6 months after PBMT treatment. First, we show results according to SG and RAG, which show improvement of blood flow and volume, pulse blood flow in the cerebral hemispheres. It was obtained in all 100% of patients. The received positive dynamics persisted throughout the observation period. According to CT and MRI, within 6 months after PBM, all 100% of patients showed a tendency to a decrease in the general involutive changes in the brain, which was accompanied by narrowing of the subarachnoid space. And for mental and motor functions, all 100% of patients who had previously had disorders in mental and motor functions showed pronounced positive dynamics. Next slide. Now we show results of the long-term effect, 1 to 10 years after PBMT. According to CT and MRI, in the following period of 12 to 24 months, there was a general involutive changes in the cerebral cortex decrease in 94.5% of patients. There was narrowing of sylvian fissures, and it was noted in 91% of patients. There was decrease in signs of non-occlusive hydrocephalus, and it was detected in 46% of patients. And there was decrease in signs of leukoariosis was detected in 25.9% of patients. In the more distant period of time, 2 to 10 years, the positive dynamics obtained was preserved, which indicates the appearance of signs of neurogenesis and regenerative cerebral changes. According to MUGA data, 11.9% of patients underwent repeated cerebral MUGA and MRA 2 to 10 years after the treatment, and 97% of those patients demonstrated preservation and enhancement of angiogenesis manifested in cerebral collateral and capillary revascularization. Next slide. In this slide, we see results of a 64-year-old male who had atherosclerosis of cerebral vessels, distal form, and had chronic cerebrovascular insufficiency. You see before and after the treatment of PBMT. In figure A, you see CT scan of the brain before the intervention. As you can see, moderate expansion of the subarachnoid space and expansion of sylvian fissures. In figure B, you see right internal carotid artery angiogram arterial phase before the intervention, where atherosclerotic lesion of distal branches of the right, middle, and front cerebral artery can be seen. In figure C, you see right internal carotid artery angiogram arterial phase after the intervention. You see stimulation of angiogenesis, collateral arterial and capillary revascularization of the right hemisphere. And in figure T, you see a CT scan of the brain. It was done 12 months after the intervention, and you can see restoration of sylvian fissures and reduction of subarachnoid space. Next slide, please. Now we'll talk about control group 1. This was still patients with intracerebral atherosclerosis and chronic cerebrovascular insufficiency. Immediately after the first course of conservative treatment, the patients did not have any negative dynamics, and 60.5% of them showed positive dynamics manifested in a moderate decrease in neurological disorders. During the early period, which is 1 to 6 months after this conservative treatment, according to SG and REG results, partial improvement in blood flow and pulse blood flow in the cerebral hemispheres was obtained in 65.9% of patients. The improvement was not stable and did not last. According to CT and MRI, in the period of 6 months after the first course of the conservative treatment, there was no significant reduction in involutive changes in the brain tissue. Results of assessment of mental and motor functions showed that all 100% of patients who had previously had disorders in mental and motor functions showed moderate positive dynamics. For the long-term effects, 1 to 10 years, according to SG and REG, during the examination in the first 12 to 36 months, 64% of 219 patients showed worsened indices. And according to CT and MRI, in the period 12 to 24 months after the treatment, there was no significant decrease in involutive changes in the brain tissue. In a more distant period, 70.78% of patients experienced an increase in general involutive changes, expansion of sylvian fissures, increasing signs of non-occlusive hydrocephalus, and of leukoariosis. Next slide. In this picture, you see results for a 76-year-old male with atherosclerosis of cerebral vessels, distal form, chronic cerebrovascular insufficiency. You can see before and after the start of the conservative treatment. In figure A, you see CT scan of the brain before the treatment, which shows convexital sulci expansion, subarachnoid space expansion, multiple deposits of calcium salts and intracerebral vessels, and ventricles enlargement. In figure B, MRI of the brain before the treatment shows multiple stenosis of intracranial branches. In figure C, MRI of the brain 1 year after the beginning of the treatment, you can see further progressing of convexual sulci expansion and signs of developing leukoariosis. In figure D, you see CT scan of the brain 3 years after the beginning of the treatment with further progressing on convexual sulci expansion and increased deposition of calcium salts in intracerebral vessels. In figure E, you see CT scan of the brain 6 years after the beginning of the treatment with further progression of atrophic changes in the brain, an increase in the expansion of convexical sulci, expansion of the ventricles, and increasing signs of non-occlusive hydrocephalus. And then figure F, MRI of the brain 6 years after conservative treatment, you see hemiperfusion decrease, multiple occlusion of subcortical arteries and arterioles. Next slide. Now we talk about the second group, and first we talk about the active group, that's group 2. Those patients had intracerebral atherosclerosis and they had previous ischemic strokes. In the immediate results, according to MUGA, a good immediate angiographic result manifested in pronounced angiogenesis, collateral and capillary revascularization, and was obtained in 94.9% of patients. During the early period, 1 to 6 months after the intracerebral PBMT, according to SG and RG, there was improvement of blood flow and volume plus pulse blood flow in the cerebral hemispheres, and it was observed in 100% of patients, while the received positive dynamics persisted throughout the observation period. According to CT and MRI, in the period of 6 months after the PBMT, the patients showed a tendency to a decrease in the general involutive changes in the brain, which was accompanied by narrowing of the subarachnoid space and a decrease in the volume of post-stroke cysts. Results of assessment of mental and motor function showed that all 100% of patients who had previously had disorders of mental and motor functions showed marked positive dynamics and an increase in IB. Next slide. For long-term results, which is 1 to 2 years after PBMT, according to CT and MRI, in the period of 12 to 24 months, general involutive changes in the cerebral cortex decreased in 95.9% of patients. Narrowing of Sylvian fissures was noted in 93.79% of patients. Decrease in the signs of non-occlusive hydrocephalus was detected in 64.9% of patients. Decrease in the volume of post-ischemic cysts after strokes was detected in 92.9% of patients. In a more distant period of time, which is 2 to 10 years, the obtained positive dynamics was preserved, indicating the signs of neurogenesis and restoration of the cerebral tissue. According to MUGA data, 13.45% of patients had repeated cerebral MUGA or MRA in 2 to 10 years after the treatment. Preservation and enhancement of angiogenesis manifested in cerebral, collateral, and capillary revascularization was obtained in 95.7% of patients. Next slide. In this picture, you see results for a female patient, 60 years old, with atherosclerosis of cerebral vessels, chronic cerebrovascular insufficiency, and ischemic stroke in the basin of the middle cerebral artery to the right. The results are before and after PBMT treatment. In figure A, you see CT scan of the brain before the intervention, which shows moderate heterogeneous post-ischemic cyst in the right middle cerebral artery region. You also see moderate expansion of the subarachnoid space. In figure B, you see right internal carotid artery angiogram, arterial phase, before the intervention, which shows occlusion of distal branches of the right middle cerebral artery and multiple stenosis of intracranial branches. In figure C, you see right internal carotid artery angiogram, arterial phase after the intervention, which shows stimulation of angiogenesis, collateral arterial and capillary revascularization of the right hemisphere. In figure D, you see CT scan of the brain 12 months after the intervention, and you see reduction in the size of the post-ischemic cyst with signs of cerebral tissue structure recovery and subarachnoid space restoration. In figure E, it's also CT scan of the brain. It was 6 years after the intervention. You see the structure of the right hemisphere cerebral tissue restored, and there is no signs of residual effects of the post-ischemic cyst. In figure F, you see MRI of the brain 10 years after the intervention. The patency and lumen of the distal branches of the right internal carotid artery are completely preserved. There is further progression of collateral revascularization. Next slide. In this slide, you see results for a female patient, 58 years old, with atherosclerosis of cerebral vessels, chronic cerebrovascular insufficiency, and extensive ischemic stroke in the occipital parietal region of the right hemisphere. It shows before and after the intervention with PBMT. In figure A, you see MRI of the brain before the intervention, which shows huge post-ischemic cyst in the right occipital parietal region of the right hemisphere. In figure B, you see right internal carotid artery angiogram, arterial phase, before the intervention, which shows multiple occlusions of the distal branches of the right medial cerebral artery. In figure C, you see the same right internal carotid artery angiogram, arterial phase, but after the intervention, which shows stimulation of angiogenesis, marked collateral arterial and capillary revascularization of the right hemisphere. And in figure D, you see MRI of the brain 10 months after the intervention, which shows significant reduction in the size of the post-ischemic cyst with signs of cerebral tissue structure recovery. Next slide, please. Следующий слайд.
Я переключил.
Oh, sorry. It looked very similar. This slide shows results for a male, 41 years old, with atherosclerosis of cerebral vessels, microfocal ischemic stroke of the right hemisphere before and after the intervention with PBMT. In figure A, CT scan of the brain shows results before the intervention, which shows moderate heterogeneous extensive post-ischemic cyst in the right middle cerebral artery region. In figure B, you see right internal carotid artery angiogram, arterial phase, before the intervention with PBMT, and it shows occlusion of the right middle cerebral artery. In figure C, you see right internal carotid artery angiogram, arterial phase, but after the intervention, you can see pronounced collateral and capillary revascularization of the right hemisphere with good peripheral blood flow. And in figure D, you see CT scan of the brain 10 years after the intervention, where you see preservation and progression of pronounced collateral revascularization of the right hemisphere with good peripheral blood flow. Next slide. Now let's talk about control group 2. These were the patients with intracerebral atherosclerosis and previous ischemic stroke that didn't receive PBMT. Immediate results. Immediately after the first course of the conservative treatment, there was no negative dynamics in the patients. 39.5% of patients had stable condition and demonstrated positive dynamics manifested in a moderate decrease in neurological, mental, and motor disorders. During the early period of 1 to 6 months after this conservative treatment, according to SG and REG, a partial improvement in blood flow and pulse blood flow in the cerebral hemisphere was obtained in 63.79% of patients. The improvement was not stable and did not last. According to CT and MRI, in the period of 6 months after the first course of the conservative treatment, there was no significant decrease in the involutive changes in the brain tissue. And the results of assessment of mental and motor function shows that all 100% of patients who had previously had abnormalities of mental and motor function showed some positive dynamics with a moderate increase in BMI. Next slide. long-term results, 1 to 2 years after the conservative treatment. According to SG and REG, during the examination in 12 to 36 months, 55.7% out of 192 patients demonstrated worsened indices. According to CT and MRI, in the period of 12 to 24 months after the conservative treatment, there was no significant decrease in involutive changes in the brain tissue. The volume of post-ischemic cysts after the stroke did not decrease. In the more distant period, 71.76% of patients showed an increase in general involutive changes, expansion of sylvian fissures, and growing signs of non-occlusive hydrocephalus and of leukoariosis. Next slide. I'll give some summary for table 3. This shows clinical results in the long-term period after treatment in the test and controls group for all patients. So for group 1, patients with intracerebral atherosclerosis and chronic cerebrovascular insufficiency, the good clinical results were produced for test group in 76.78% of patients, and in control group only for 10.5% of patients. Satisfactory clinical results for group 1 for test group were produced in 20% of patients and in 15% of control group patients. For group 2, which were the patients with intracerebral atherosclerosis and progression of microfocal stroke, good clinical results were shown in the test group for 88% of patients and for control group only in 21% of patients. Satisfactory clinical results were shown in 10% of test group patients and 24% of control group patients. Group 2, patients with intracerebral atherosclerosis and progression of mid-focal stroke, good clinical results were shown in 60% for test group, and they were not shown in the control group. Satisfactory clinical results were shown in 24.8% in test group and in 19% of the control group. For group 2, which were the patients with intracerebral atherosclerosis and progression of microfocal stroke, good clinical results were shown in 20.7% of patients, and control group didn't show any results in that category. Satisfactory clinical results were shown in 37.9% of patients, and control group didn't show any results in this category. Next slide. Conclusions. PBMT is a pathogenetically and physiologically sound, effective method for the treatment of cerebral ischemic and neurodegenerative lesions. When conducting intracerebral transcatheter PBMT, the energy of the low output power laser of the red region of the spectrum affects cerebral tissues in a complex manner. Unlike other treatment methods, transcatheter intracerebral laser PBMT stimulates angiogenesis, causes collateral arterial and capillary revascularization, restores ATP metabolism in neurons, improves cellular and tissue metabolism, stimulates neurogenesis, and causes regeneration of tissue structures. This complex laser action during PBMT allows to significantly improve daily life activity, restore cognitive and mental functions, reduce the level of dementia in patients with different severity of cerebral ischemic lesions, thus allowing them to return to active daily life. The obtained positive clinical result is observed for a long time. In general, conservative treatment has a positive clinical effect only in the early, lighter stages of cerebral ischemic lesions. I think that's it. Thank you.
Thank you. Thank you so much, both. Even it was a wonderful talk, and Liza, it was an amazing interpretation. They can stop sharing so that we can all see each other and start the discussion.
Лиза.
Значит, Иван Васильевич, значит, они нас поблагодарили за то, что была очень хорошая презентация. Все было всем очень понятно. Большое вам спасибо. И они сказали, что сейчас начнут вопросы.
Очень хорошо.
I just translated, Dr. Kasana, what you said.
Great. So even if you want to stop sharing, we'll start the discussion.
Иван Васильевич, можете перестать показывать презентацию, пожалуйста?
Хорошо, все.
Okay, so while I wait to see everybody else, I have a quick question. I might have missed this. I was curious whether I assume the conservative treatment was a stent placement. And I wonder if in the people who received PBM, also a stent was placed intravascularly or not.
Dr. Kasana, can you repeat for me so I know how to translate?
Sure. So I'll break it down. So in the conservative treatment, was a stent placed? Was that the conservative treatment?
One second. Иван Васильевич, в conservative treatment, не знаю, как сказать по-русски, но которые не получали,
Понял.
да? У них же ничего, им туда ничего не вставляли, им только лекарства давали, правильно?
Только медикаментозное лечение. Достаточно распространенный метод, как сказать, подборка распространенного консервативного лечения, принятого во всем мире.
Okay, so Dr. Kasana, to answer your question. So for the control group, there was no intervention with any stents. The only thing they received was the medication that were listed in one of the slides, I think what table 2 is. So the same conservative medications were also administered to the active group, but after the PBMT treatment. So essentially the difference is they both had conservative treatment, but for the active group, they received PBMT before the conservative treatment.
Okay, I guess I have a follow-up question. Was angioplasty done? So was there a balloon used intravascularly to dilate the stenosis in the conservative treatment and in the PBM?
Okay, I'll try. Angioplasty, right, you said? Иван Васильевич, они спрашивают, было ли сделано вот это ангиопластия, я не знаю, как по-русски это сказать.
Ангиопластика, так и звучит.
Это было сделано и в conservative группе, и в активной группе?
Нет, только в активной группе.
Okay, so Dr. Kasana, it was only done for active group. It was not done for the control group. Oh, sorry, yeah, for the non-active control group.
So basically, if I understand correctly, the group that received the red light also received angioplasty.
Yes.
While the control group only received the medications.
Exactly, that's correct.
Okay, so how do you disentangle the effect of the red light from the effect of the reperfusion that you create by using angioplasty?
Okay. Иван Васильевич, вопрос такой. Как вы можете... Sorry, I have to translate disentangled. I don't know how.
No worries.
I will use Google Translate, please. Как вы можете доказать, распутать, что вот этот red light, да, то есть вот это сам treatment with PBMT, что результат был именно от red light, а не от того, что вы делали ангиопластию? Вот такой вопрос был у доктора Касана.
Дело в том, что, понимаете, ангиопластика – это не совсем то, это совсем другие манипуляции. Есть черезкожная перкутанус, транслюминальная ангиопластика, но она делается с лазерами высокой мощности. Мы применяли здесь исключительно гелий-неоновый лазер.
Окей, дайте я попробую. So, what Dr. Maksimovich is saying, that in their case, they only used the gel neon laser,
Yes.
right?
Да.
And not the lasers that can create the effect that I think you are alluding to. So they're saying that the gel neon lasers do not provide that kind of effect.
So sorry if I'm interrupting. I think the angioplasty was used to insert the laser. Is that
Yeah, that's what it was used for, right? That's
okay?
correct.
And not to
Not to treat. Yeah, it was just used so that they can, from what I understand, they can insert the catheter so it can go into the place where it had.
Hamza, I didn't know you knew Russian. It's amazing. Okay, so I understand that to introduce the laser, you have to create space for the laser to penetrate through the vessel. However, you know, is pharmacological treatment, and again, I'm a psychiatrist, if pharmacological treatment the standard of care, or would it be rather pharmacological treatment and angioplasty for the control?
But they didn't use angioplasty for the control group.
Right. But you know, if you do the angioplasty and you dilate the vessel, naturally, so you see a reperfusion. And so how do we know that the reperfusion that you're seeing in the red light treated patients is in fact very much related to the light therapy? What we have to compare is a group that doesn't have the angioplasty. And so in the active group, we have two potential therapeutic effects.
So you still have the same kind of question a bit.
So I don't know if you want to ask one more time to see what is.
Let me try. Иван Васильевич, у них все еще вопрос с этой ангиопластикой. Вот что сказал доктор Касан. Он сказал так, что в активной группе перед тем, как давать лекарства, да, вы сделали две вещи. Вы расширили сосуды, а потом запустили... Нет?
Значит, смотрите, ангиопластика это не совсем... Мы тоже занимались этим вопросом еще пойти 40 лет назад, в 80-е годы, когда это было тогда очень модно. Ангиопластика возможна на более крупных прямолинейных сосудах. И она подразумевает воздействие, вы понимаете, либо лазером, тогда это лазерная ангиопластика, либо это стентирование, тогда ставится стенд, либо это баллонная ангиопластика, когда просто расширяется баллон сосуд. То, что делаем мы тоже делаем это давно и начали в начале 80-х годов. Тогда мы это, еще тогда не было термина фотобиомодуляция. Мы это называли лазерной реваскуляризацией. Вот. Но это, в принципе, понимаете, когда был введен термин фотобиомодуляции, хотя он мне не очень нравится, но мы это стали называть фотобиомодуляцией. Здесь нет никакого, как сказать, расширения сосудов, то, что подразумевается под ангиопластикой. Это просто воздействие гелионионового лазера на сосудистую структуру мозга и на ткань мозга. Больше ничего. Это типичная фотобиомодуляция. Только с той разницей, что она делается изнутри. Она делается изнутри, и лазерная энергия подводится к головному мозгу по сосудам.
So, мне кажется, что он не это спрашивает, а вот что он спрашивает, если я правильно поняла. Для того, чтобы вставить этот катетер, да, который пошел в мозг, да? Что вы для этого сделали? Он так понял, что вы использовали что-то, чтобы расширить сосуды сначала, чтобы прошел катетер.
Нет, дело в том, что, понимаете, катетер, сам лазерный световод, он очень тонкий. Он, понимаете, от 20 до 100 микрон.
Okay.
Понимаете, и он сначала заводится, там, в принципе, это вы читали, там все это написано. Понимаете, ставится в бедренную артерию интродюсер, Ну, интродюсер – такая трубочка маленькая с клапаном. После чего проводятся направляющие катетеры, которые пластиковые рентгеноконтрастные направляющие катетеры. Через эти катетеры заводятся через сонную артерию в головной мозг. Потом через этот катетер транслюминально заводится лазерный световод. То есть инструмент, который передает излучение лазера в головной мозг.
А ангиопластика была использована во всем
Нет,
этом?
нет, это не ангиопластика. Нет, это не ангиопластика. Ангиопластика, понимаете, это совсем другое.
Okay, let me try and translate this. So, Dr. Kasana, I think this is where my limitation of my understanding of medical field might not be very good for this discussion. But from what I understand, Dr. Maksimovich is saying that the angioplasty, the way you understand it, was not used at all. So essentially, so it was not used at all. So they just put the catheter in the, куда, в бедро вы вводили катетер, да?
В бедренную артерию.
In the leg, through the artery in the leg, right? And then they just somehow moved it up to the brain and then started using laser. So there was none of this side effect of angioplasty that I think you're implying. I think it was not used.
Okay, thank you so much, Ivan.
Еще раз скажите, понимаете, это только чисто воздействие лазерного излучения, которое подводится непосредственно в ткань головного мозга. Но при этом это излучение активно воздействует на сосудистую стенку и вызывает ангиогенез, за счет чего открываются коллатеральные сосуды и начинают прорастать новые сосуды.
Yeah, so he's saying it was purely it was purely the light that was used in the active group. There was nothing.
Thank you so much. That's really helpful. I just want to let sorry for taking so much time from the discussion. I think this is an important point to clarify. So I see Hanli, but also there is a question in the chat that I will read. Would some of these fantastic results be due to more systemic effects, like stimulation of free-floating mitochondria in the cerebral blood flow? So I guess the question is whether Dr. Maksimovich believes that the effects were related to the circulating mitochondria, or was the effect of the light penetrating in the tissue, in the white matter, in the gray matter?
Okay. Hold on. Give me 1 second. I'll try to translate some of it.
Also, maybe it might be worth asking about whether there was a quantitative assessment also of the improvement through the imaging.
Okay. Давайте, so I'll first start with this question. Dr. Maksimovich, могут ли некоторые из этих результатов быть обусловлены более системными эффектами, например, стимуляцией митохондрий в cerebral...
Я понял.
Да.
Лиза, понимаете, объясните еще одну вещь. Понимаете, доктор Касана берет гелий-неоновый лазер и светит через кожу головы и через череп на мозг. Понимаете, кожа головы и череп поглощает большую часть лазерной энергии. И до головного мозга доходит небольшой процент. Либо доктор Касана делает то же самое через нос. Но там тоже есть свои кости, и до головного мозга доходит небольшой процент. То, что делаю я непосредственно ввожу лазерный световод через сосуды головного мозга в ткань головного мозга, И за счет этого вся лазерная энергия поглощается головным мозгом. Гелий-неоновый лазер, значит, излучение гелий-неонового лазера распространяется на 2-4 сантиметра, ну 20-40 миллиметров в ткани головного мозга. И при этом все 100% тут попадают именно в ткань головного мозга. Что касается естественно, воздействие идет сложное. С одной стороны, это приводит к ангиогенезу и к тому, что открываются коллатерали и развиваются новые сосуды. Второе, естественно, это воздействует на клетки головного мозга, восстанавливает в митохондриях нормальный обмен. Это, наверное, я долго, давайте мы половину.
Давайте я не смогу это все перевести. Давайте я сначала расскажу, что... Потому что вопрос был не о том, как отличается то, что вы делаете, от того, что, например, делаем мы, который мы светим в мозг через... Вопрос был больше, что я не очень понимаю этот вопрос, честно говоря, что там что-то...
Лиза, я просто хочу объяснить, что, понимаете, я уже это говорил, но повторяю, это не ангиопластика. Это в чистом виде фотомиомодуляция, но только которая производится непосредственно на ткань головного мозга.
Okay. Давайте я... I think the way Professor is answering is that the stimulation is happening in the brain itself. It's not the devices that stimulate the brain from outside or even through the nose. The biggest difference is that the stimulation happens inside the brain. So he's saying that was essentially his answer, that there is no angioplasty, that it's directly because of the light that's administered directly to the brain area inside the brain.
So I think he meant that it's really the effect through the vessel wall onto the brain tissue. I had a quick question from Hanli Liu. Is all of this data published and available in PubMed?
Окей. Скажите, они спрашивают, опубликовано ли это в каких-то журналах, и как на это можно посмотреть?
Ну, это можно посмотреть, это много где опубликовано. Ну, в частности, доктор Касана, по-моему, состоит в редакционной коллегии у профессора Хамлина, и там тоже это опубликовано.
А вы не могли бы, а это есть на PubMed? У вас есть вот...
Да, на PubMed это есть. Ну, по крайней мере, которые опубликованы у Хамлина, они есть.
А вы можете послать эту информацию?
Да, конечно, пожалуйста.
So, yeah, it is published. It's available in PubMed. And Dr. Hamlin is on the review committee. So it was one of...
Еще и в книге Хамлина.
Yeah, and it's also in the book published by Dr. Hamlin.
В журнале.
And in the journal. So Dr. Maksimovich will provide PubMed ID so everybody can look at the results.
Fantastic. Marnie, we just have 1 minute for a quick question, a quick answer.
It's really a very quick question. I was just curious what is the diameter of a vessel that the laser itself directly can reach? In other words, does it stop at the origin of the middle cerebral artery? That's a nice big one, but how deep can they go? I mean, there are very tiny, small lenticulostriate vessels. You don't have to worry about that in Russian and English, in the brain. And a lot of those are sources, especially with high blood pressure cases, for an area of ischemia. So what is the diameter that you can get into of a vessel?
Yeah, thank you. I'll try to translate. Доктор Максимович, вопрос такой. Вот этот катетер, который идет к мозгу, какой самый маленький, какой диаметр самый маленький, куда он может проникнуть?
Ну, понимаете как, мы проникаем, ну, если диаметр самого световода, он от 20 до 100 микрон, то есть мы можем проникнуть в 0,5 миллиметра.
Он от 20 до 100 микрон?
Да.
Let me say that. So he's saying that the diameter of the the catheter that transmits the light itself is, еще раз, 20 до 100, да?
От 20 до 100.
It's from 20 to 100 microns.
Oh, my goodness. Okay, that's really small.
Very small. И поэтому, доктор, как далеко он может пройти, в какую артерию?
Ну, в артерию диаметром там 0,3-0,5 миллиметра.
So it can get into the artery, which is 0.3 millimeters.
0,3.
Точка 0,3?
Нет, просто 0,3.
Точка 3, да? Yeah.
Да, точка 3, да.
0.3 millimeters.
Oh, okay, thank you. Because some of these strokes are very deep in the brain and very tiny vessels, but I know the red light's going to go all around anyway. But I was just curious how small he could get it. What was the diameter of the smallest? But that's pretty impressive, 0.3 millimeters. Okay, thank you. Yeah.
Thank you so much. Thank you, Liza. Thank you, Dr. Maksimovich. This was very inspiring. You know, I can think of more questions, but we've passed the time today, and this was really inspiring. Thank you all for being here. To be continued. Please continue following us, and thanks again.
Thank you. Bye-bye.
Все?
Всего доброго, да. Они
Лиза,
поблагодарили.
еще секунду, Лиза. Можете сказать доктору Касан, если он возьмет своего пациента, пускай даже ребенка.
Dr. Kasana, can you wait 1 minute? I think Dr.
Sure. I'm happy to.
Okay.
And quick question, Hamza, did you record it all?
Yes, I'll stop recording now.